The 2011 ASCO annual meeting has kicked off in Chicago. Dr. Lee Schwartzberg, the editor-in-chief of Community Oncology, talked to us about the highlights of this year's conference and the impact of some of the important studies on clinical practice.
What we're going to see, I think, in the plenary session is something that we've been very excited about since last year's ASCO, which is in the field of melanoma. Melanoma is a disease that for 25 years did not have a new drug since DTIC was approved by the FDA, and that has been the standard of care, which community oncologists have largely abandoned before this in favor of other, but not as well established new types of approaches to this disease. Now we have new approaches to melanoma that's advanced, an otherwise very fatal disease. And in the plenary session this year, we're going to hear about two drugs that we've heard about before, but what's important this year, this is first-line data in metastatic melanoma. I think there's some interesting things going on in the GI arena, particularly an area that we haven't heard a whole lot about in the last few years in terms of new advances, which is rectal cancer. There's a real change in the way the studies are being conducted today from the way they were 5 or certainly 10 years ago. We're moving into an era, or we have moved into an era, I think it's fair to say, where molecularly targeted therapies have become preeminent. And we used to treat patients with chemotherapy, which of course are targeted therapies as well. The target tends to be DNA in that case, and a sort of a broader target than more specifically. But we now clearly understand that most, if not all, cancers are comprised of subsets. And these subsets may respond very differently, even have different natural history, depending on the mutations and the pathways that are involved in each of those subsets. And perhaps the most significant change is the way drug development is being done. Used to be, the paradigm was you did a phase 1 study, and the purpose of the phase 1 study is to push the dose to the highest level where there was undue toxicity and then back off a little bit. And that was the dose that was taken into phase 2. We weren't necessarily even looking for responses in phase 1. That's all changed. If you have a target and it's a validated target, you should see results in phase 1. And so that really helps drug development because you don't have to waste all these resources going through all these studies. Drugs can be killed early on if they don't show the benefit in phase 1. And if you think about that conceptually, that means that's a real paradigm shift because that means that we're really identifying the right therapy for patients early on. And hopefully that will result in more drugs being approved much faster than in the past. Now, that remains largely a promise rather than a reality, but I'm very excited about that. This is a very challenging and exciting time as a practitioner of oncology, and I've been doing this 25 years, and it's getting more interesting, but also more challenging than it ever has before. And part of that is the recognition that healthcare needs to reform in this country, and we've started that initiative now. As it relates to oncology, the most important aspect is the expense of cancer care, and that's going up and up and up, and it's really not sustainable. So the question is, how do we change things? How do we change the way that we do things?